resuscitation, not only CPR. CPR is most important component of resuscitation. So any life-threatening conditions, could be acute coronary syndrome, could be stroke, somebody has been poisoned, somebody has a drug error, somebody has a trauma, anything. And extreme is cardiac arrest. Extreme condition is cardiac arrest, but which are reversible. That's where your role comes. It has to be a reversible cause. So for that, you have to work in a very tight time frame. And we call it the rule of 10 seconds. In 10 seconds, this has to be done. So this is what is a systemic algorithm is necessary. You have to act in a very specific time frame. You can't keep on extending. If you don't feel carotid, don't keep on checking. Don't go on the other side and check it. 10 seconds you don't find carotid means assume there is no carotid. Quick decision making and strategic thinking. And for that we need very good pre-planning of the algorithm. And this is the reason internationally for everything guidelines are formed. And when we are not the scientists, when we don't do research, we have to follow the guidelines which are made by experts. That is very, very important. There is some water. Actually, last 4 days I got so bad throat. Now the first guideline was made in 1966 by American Heart Association, and which is most prevailing guidelines in the world today. And then it was followed by many countries. Then in 1902, International Liaison Committee was formed. It's a body above AHA. And now there are 8 councils in this, and we are part of it. So we had a demand in India. Our status of training was very poor, and we were dependent on AHA up till now. Till we started working in 2012, and 2017 we made our guidelines. So what we wanted was our own single curriculum across the country, fitting to Indian culture. Now, exposing victim on the road, exposing somebody in the public place is a difficult thing in our country. And you delay the resuscitation. It has to be cost effective and should reach to everywhere, smallest corner with very compromised infrastructure places also. So that's why Indian Resuscitation Council Federation was formed in 2017, and it made its guidelines very much feasible to us and compatible to the all international guidelines. And we became the member of ILCOR in 23 with a lot of struggle. And I had a time to talk to the European Council meeting in 23 also. We presented there and they accepted us so well that you guys are, and now last February, again I was invited to Netherlands. They appreciate the Indians so much now that they've got that we have 12 people in the member of ILCOR to decide the guidelines. That's a very proud moment for all of us. So these 3 guidelines are created. Now this I'm going to give you the brief idea. Compression only life support, the name suggests what? Only compression. You give only compression. So compression only life support, who are the beneficiaries? Every citizen of the country, because sometimes sudden collapse happen where no doctors, no paramedics are there. Sometimes I feel even our clinics are like as good as outside the hospital. But we also fall in the same things, because somebody collapses on the airport or in function or here, what do we have? Only 2 hands. Even if we are learned, even if you have a best cardiologist sitting here, he also has only 2 hands. But your 2 hands can do miracle, can save somebody's life. That is what I want to emphasize today. So for anyone who collapses outside, see the video. It's a real-time video. Can you hear the sound? Sound, please. So that is a real-time video. And see the lyrics, accidentally this lyric. And this happened in my hometown, Junagadh. A PI in his own retirement party, he was reciting. And his son was recording. That was a couple, young couple in Andhra Pradesh. It's a true video, true. And Haldi Rasam. And this is in a bank. And this is our MD doctor. This has been viral in whole country. This happened in 1924 in Bangalore. She is an MD medicine doctor. She finished the round at about 10, 20, 30. And I have a full long video. Nothing was done to her for another 3 minutes. And gym, very common. You know who's the celebrities when they collapse in gym, they come in the newspaper and media. You remember any? Raju Srivastav, Siddharth Shukla, KK the singer on the stage in Kolkata, our beloved past president, APJ Abdul Kalam, he was giving a lecture in Shillong, IIM. While giving the lecture, he collapsed. So, and if you remember, 2023, Garba festival in Ahmedabad and all Gujarat. 36 people while performing Garba collapsed. Maximum in Vadodara, then Surat, then Baroda, and one of our family member also. You must be remembering that. So, question is, if you are around such incidents, imagine this can happen in the hospital also. What will you do? So try to understand the science behind this and the philosophy. What was common in all kind of incidences which happened? There was a Haldi Rasam, there was gym incidences, there was a Sangeet Sandhya when middle-aged person was dancing, young couple on the stage, bank. What do you think is the common? Excellent. First answer is sudden. No one complained the chest pain, ghabraman, sweating, dizziness, giddiness, short of breath. Nobody complained. And second common thing was all were active people. They had left home for some good cause. They all were active. So active person suddenly collapsing outside the healthcare institution any time of the day, there are no doctors or no paramedics who are trained around. So this is what he said. Now, when you see somebody collapsing, suppose here or maybe in cafeteria or anywhere you are in somebody's function, what is your first thought if you see somebody collapsing? You witness it. What is your first thought? Yes? Yes. So what is the worry? Most important worry is cardiac arrest or no cardiac arrest. For that, the algorithm comes with call for the help. That comes third. So my first worry is yes, no cardiac arrest. Because if it is cardiac arrest, I don't have time. If it is no cardiac arrest, so what is the important first step you have to do? Establish there is no cardiac arrest or cardiac arrest. Clear? How quickly you do it. And that's where the rule of 10 seconds applies. 10 seconds, 10 seconds, 10 seconds, 10 seconds, you have to do one activity. That's what we give aggressive training in the workshops, as he mentioned. So what is the immediate priority? Is the cardiac arrest or? And this is the algorithm. Now, talking about yellow algorithm, I said compression only life support, which has happened outside and there are no doctors. If you have trained the citizen, what is one liner motto of training citizens for compression? See, everybody may not survive. Maybe 1 out of 10, maybe 2 out of 20, maybe 4 out of 30. But if he survives, he should survive without neurological damage. That is our goal, not for survival when it is outside. Because many times we have seen Raju Srivastav himself. He had a cardiac arrest in gym. By the time he reached to AIMS emergency department, he had a sinus rhythm and nothing was done in between. But he died of multi-organ failure on 29th day. That's a classic example. If somebody would have done the compression in the gym, he would have been in much better condition today. Though he already had one stent done and he was a patient of ischemic heart disease. But what happened was sudden. He needed support. So that is why our primary goal is give a good quality life. And for that, brain survival is the most important. So if somebody collapses like this, and within 20-30 seconds, if somebody starts compression, you start perfusing the brain with the oxygen within the body. There is a lot of oxygen within the body. 5 liters of lung air and 5 liters of blood circulation has so much oxygen content, is only you have to send it to brain. And that's why initiation of compression, once you establish cardiac arrest, is very, very important. And that's why most important step is to establish cardiac arrest. Now, second guideline is basic cardiopulmonary life support. It is for every doctor, every paramedic, and now even allied medical branches also we are treating, because our most nursing homes have Ayurvedic doctors who are medical officers. And they are the one who is in the front with the patient, not we. So this is for every doctor to learn, and every doctor must learn correctly, whether it is a cardiac arrest inside the hospital or outside the hospital. And this one-line motto is a true cardiac arrest management. You keep perfusing the brain and the coronaries till you diagnose the cause of, reversible cause of cardiac arrest and treat the cause. Then only it recovers. And the third one is a comprehensive cardiopulmonary life support. This is for every doctor and exclusive paramedics working in critical areas of the hospital. Critical areas are emergency department, critical care, operation theaters, cath labs, interventional radiology rooms, procedure rooms, endoscopy rooms, dialysis rooms. These are critical areas. Every staff member should be trained for this, because their code blue doesn't work. There you have to have the inside staff only trained for this purpose. Now, this CCLS guidelines when we teach is for the events happening within the hospital, where there is our obligation. Now, our obligation is nobody comes brought dead to the hospital. They come as a patient for some elective procedures. They come as a patient's attendant. Ourselves, our staff members, our vendors who come to supply food chain and medicines and all. So anyone entering our hospital premise and he collapses there, it is our responsibility. That's why everyone has to learn this. That is very much been focused now in the world. And your aim is prevention of cardiac arrest. So COLS aim was, if he survives, he should survive without neurological damage. BCLS, true cardiac arrest management for survival. And the CCLS is in-house, where prevention of cardiac arrest is very important. And that's what we focus. We are not going to talk about that today in this class, but that is what we focus for 2.5 days. So now, these are the causes of cardiac arrest. We have given the mnemonic hit the target. And believe me, there is not a single cause which is not there, which is a reversible cause of cardiac arrest or pre-arrest condition in this list. And you need to think as an orthopedic surgeon, which cause can fit if your patient has a cardiac arrest. Hypoxia, hemorrhage, but don't think to your field. Think as a broadly as a doctor. Anything can happen in an orthopedic nursing home. Anything can happen in an orthopedic hospital. Deep vein thrombosis, drug errors, intoxication, overdoses, hypoxia, injury, trauma, so many things. Everything is there in this, which you need to think, and you need to think and do the homework that if these things happens, what I'm going to do. This is to prevent cardiac arrest, or if cardiac arrest has happened, to treat the cardiac arrest. So this is very important slide for causes, reversible causes of cardiac arrest. Now, most important thing which I said, my first priority when I see somebody has collapsed is a cardiac arrest or no cardiac arrest. So what do you look? How do you find out what is cardiac arrest? And first clinical sign is responsiveness. He said, somebody said here. Check the responsiveness. Step on the shoulders, facing the patient's face vigorously on the shoulders. Don't shake him. He has fallen, he may have cervical spine injury. We never know. So hit with both the hands together and give a physical stimulus and give a verbal stimulus. Shout. With that person who is in shock or something, he may start breathing. So if he has stopped breathing, he will start breathing. Now, when you do this for 10 seconds, in 10 seconds, scan the body for signs of life. And the signs of life, when you do this, at least 3 times in 10 seconds, step the shoulders and shout. And scan the body for, is he trying to wink the eyes? Is he starts breathing? He starts coughing? Is he trying to turn the head towards you because you are on one side? Is he trying to move the limbs? Is he trying to cough? All these are the signs of life, and then 10 seconds you have to assess. And if you don't find this, you have to assume he may have cardiac arrest. It's the first clinical test and only clinical test, first test in the world in all the guidelines, responsiveness. And second sign is the carotid pulse. Now, carotid pulse checking is not easy. Since 2005, my all postgraduates, I had made a rule that as a part of pre-anesthetic checkup, you have to check carotid pulse, one student to one patient, and always on one side. Because you look in the classroom, you look at the necks in the classroom. There is so much anatomical, architectural variations in the neck. Long neck, slim neck, short neck, large circumference. Some people we find now, no neck, mandible, shoulder directly. So these are the different genders. So to palpate carotid pulse and you to ascertain there is no pulse in 10 seconds is difficult, humanly difficult for every doctor. So in my course, homework is 50, logbook, 50 carotid pulse I palpated. My operation theater for last 20 years, one paramedic when patient comes on the table will palpate the carotid pulse. One paramedic, one patient. Second patient comes, another paramedic. So they get a confidence to tell when actually there is no pulse. Because that is the only sign to establish carotid pulse, cardiac arrest in victim. Everywhere in the world, in whole medical science, there is no other way. So carotid pulse checking, where do you do it? You have to do it at the, palpate the larynx, run your 2 fingers side, on the side, sternocleidomastoid muscle and in the gap, in the groove. That's where you palpate and not taking more than 10 seconds, 10-second rule. So do it, rule for 10 seconds. Now, you establish a cardiac arrest. So how much time you took? Algorithm says, first, is this place safe for me? 10 seconds. Is responsiveness is there? 10 seconds. You need to ask someone to call for the help. He said 10 seconds. And for 10 seconds is for this. This is the fastest you can do. Now, my own environment, I can save time for safety. Oh, it's a good place. 5 seconds, I know it's a safe place. So I start saving. So you should not take more than 30-40 seconds to establish cardiac arrest when you have witnessed it. So the output depends upon the time cardiac arrest took place and time you recognize may not be in your control sometimes because you could not reach there. Scene may not be safe. So, but that time you need to try to shorten out. If you have witnessed, it should not be more than 5-10 seconds. Now, time you establish cardiac arrest and time you initiate compression is fully in your control and should be done within 1 second only. You establish cardiac arrest, start with the compression. And Indian guidelines suggest that with the close on you start. Don't waste your time in exposing the victim because exposing delays the compression. Your aim is compression, compression, compression. As early as possible, you need to initiate compression. So this is what you should not miss out. So time the cardiac arrest happened, the time it was recognized, the time compression initiated, and high quality CPR. Now, high quality CPR has lot of micro details, which quickly I'll run because this is not a classroom, this is not a course. That's why I'm going fast. So cooperation is the most important component of CPR, and that's what I'm going to focus a lot. Now, where you do it? In the center of the chest, lower half of the sternum. So most important is rescuer's own ergonomics, your hand placement, midline 2 fingers above the xiphoid process, rate at 120 per minute, at least 5 centimeters but not more than 6 centimeters depth, and 1 cycle of 30 compressions, and then such 5 cycles. Complete recoil of the chest to feel the heart again. Don't lift your hand from the chest, because in 1 second you are giving 2 compressions. Your hand may land centimeter here or there. It can harm the, if you land lateral, it may fracture the ribs. Hand always touching the chest and uninterrupted. For that I will show you one video, and chant loudly 1, 2, 3, 4, so that everybody will know that CPR is going on. Chanting 1 to 30 in medical science is only for CPR. And you give breaths if possible. If you have devices, you give the breaths. And how do you give? 30 compressions and 2 breaths. That is 1 cycle, and you finish 5 cycles. Now, breath can be given by mouth to mouth, preferably with a barrier device. We have passed through the COVID stage, so we would not like to do mouth to mouth, particularly with a stranger. So mouth to mask is another device where we have a pocket mask available. I have seen in ambulances in Germany also, they hang on the, when they go out to attend the victim, they have one mask hanging on their belt. And Begwal mask device is the device we use in the, these are the devices. Now this video, what is important is to stress upon, when you start compression, is the first, second, third, fourth, 6, 7, 8 compressions, the perfusion pressure is developed. You can see that?
With each good, effective compression,
the moment you interrupt, it drops.
Which will move blood around the heart.
So in 30 compressions, only 22, 23 compressions are effective compressions.
So
and that's why we calculate it as the compression fraction. How much time your hand is on the chest and how much time is the effective compression.
Down at least 2 inches allows for the heart to be squeezed and blood to move out.
That's why there should not be interruption more than 10 seconds. And you have to interrupt to check the pulse again, to check the breathing and pulse together. If you want to defibrillate, during defibrillation you should be interrupting. Otherwise, interruption should never ever be more than 10 seconds between 5 cycles. In 5 cycles, only 3 seconds gap. Now, VF and VTR, this every doctor should know, are the common conditions in cardiac arrest in adult, maybe cardiac origin, maybe non-cardiac origin also, and it should be picked up early. So these are shockable and non-shockable. Now defibrillation is one which everyone must learn, and you have been seeing AEDs. I am going to talk only AED. AEDs you find now on the airports and all malls and all places. So the AEDs are, these are the machines. They are automated. You don't have to interpret the rhythm yourself. This is how instructions are there. You place the leads and start analyzing itself. And it guides that you deliver the shock. Now this guy I want to mention. Anybody knows him? One in the lower picture. Upper one is an anesthetist, of course, in Mumbai. And his friend, you know him? Last February, first week, this orthopedic surgeon, Dr. Amit Jain, I have put this slide with his consent because this was viral all across the country. He was in a gym and he collapsed. And he didn't know that Dr. Kalpesh Shah, anesthetist, was behind him on another treadmill in the same gym. When he collapsed, he rushed and defibrillated 3 times with AED available in that gym. And he survived. 3 shocks. He had some conduction problem. He was rushed to the hospital with 60, 70 blood pressure, not conscious. On 3rd day, he became conscious, and he was fully diagnosed to have some defibrillation problem, and he was placed with an AICD device. He's working now. So that's the value of defibrillation. If I exaggerate to enhance the value of defibrillation, if you witness cardiac arrest, if the rhythm is shockable and you have a defibrillator in your hand it's a priority even over the compression. So that is what he survived. And this letter I have written, his own words.
Divan, if you can be,
we have
Divan, if you can be little bit
faster, yeah.
Yes.
All right. So this is the one you must learn, and this we teach in the course, automated external defibrillator. Second is supraglottic device your anesthesiologists are using. Is the most preferred friendly airway device for resuscitation, and that changes the 30:2 to continuous compression and continuous respiration. I'll skip this little video of that. This you have seen it, no? These devices people are using. Every doctor must learn this.
A proficient user can achieve insertion of iGel O2
As simple
in
as
less
that.
than 5 seconds. Introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate. It is not necessary to insert
Every
fingers into the
paramedic
patient's mouth.
taught this across the world.
Glide the device downwards and backwards along the hard palate with a continuous
It
but
fits
gentle
right over the
push
railings.
until a definitive resistance is felt. Do not apply excessive force. The tip of the airway.
And third is intraosseous medications when vein. So these modalities of emergency medicine, supraglottic device, intraosseous, you know it. Nowadays we have this power drill available. This I am showing one video of my patient. This I don't have to teach to you people actually, but this is being extensively being utilized outside in the ambulances when 140, 160 kg patients, the vein is not available. Put as little support above the knee and it works like IV. Any drug, any fluids, blood transfusion, blood sampling, there is a power driver available. This is available now in India for last many years, and there are special cannula for that, which I showed in the previous slide. As simple as that. And this is being extensively used outside, even in cardiac arrest for medications. And this we must propagate. Yeah. So this is my actually summary. There is a scope of improvement. Early recognition is the key to improvise the outcome. High quality CPR, as I mentioned the points rapidly. And AED intraosseous approach and supraglottic device are very, very underutilized management in our country, which we need to learn much better way, and we can propagate. I recently had a patient witnessed in Narendra Modi Medical College and LG Hospital, emergency department. They did a transcutaneous spacing, which is the last thing. And with the transcutaneous pacemaker, they sent to UN Mehta and patient survived. So transcutaneous spacing is another thing which is very important for every doctor to learn. Forget that you are orthopedic surgeons. So that's it. I'll end my presentation here. This I already said. Thank you.